Hereby, I open this academic ceremony in which Ilia Bresesti will defend the academic thesis, Respiratory Monitoring and Optimization of Fetal-Neonatal Transition in High-Risk Infants. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much and good morning, esteemed Pro-Rector, esteemed Chairman and esteemed opponents. It's a great honor for me to present today the main findings of my doctoral work entitled Monitoring and Optimization of Fetal to Neonatal Transition in Preterm Infants. Let's start with a little bit of background about the transition from intrauterine to extrauterine life, which is one of the most complex and vulnerable moments in human physiology. In term infants, this process is usually smooth, but in preterm infants, it can become really difficult. Their immature lungs, underdeveloped cardiovascular control, and unstable circulation expose these babies to a high risk of both immediate complication and long-term sequelae. In particular, the abrupt switch from placental gas exchange to lung-based respiration requires extremely rapid adjustments in the respiratory supports provided in the delivery room. Any failure or any delay in these adjustments can have profound consequences on oxygen delivery to vital organs and so to their proper long-term functioning. In daily practice, clinicians rely primarily on two vital parameters in the delivery room: heart rate and peripheral oxygen saturation. These measurements are accessible, are widespread, are easy to be applied, easy to be interpreted, but they provide only a narrow perspective. They do not capture the complexity of lung aeration, cardiac output, or cerebral oxygenation. And as a result, these interventions are often based on incomplete information. This can lead to two main risks. On one side, the undertreatment, where delayed intervention may worsen hypoxemia and bradycardia, or overtreatment, where excessive or inappropriate ventilation may cause both lung and brain injury. Therefore, the first minutes of life in the delivery room are crucial, not only for the short-term stabilization, but also for long-term neurodevelopmental outcomes. This provided basically the rationale for my research to explore and validate a smarter real-time monitoring tools which can allow clinicians to personalize the support, reduce complications, and improve safety from the delivery room to the NICU. Specifically, the objective of my doctoral work were to investigate the impact of bradycardia and hypoxemia and the interplays on systemic and cerebral oxygenation, to evaluate the contribution of advanced monitoring tools in optimizing tidal volume and heart rate recovery during stabilization, to assess the feasibility of transcutaneous CO2 monitoring in the delivery room, and to explore different ventilatory strategies, specifically bi-level CPAP, and their effects on respiratory function in preterm infants. Altogether, this study aimed to provide a more comprehensive and personalized approach to respiratory support during the first critical minutes of life. These are the 4 projects that I have included in my thesis, which I'm going to describe in more details in the following slides. The first study was published in Resuscitation and explored how bradycardia interacts with hypoxemia and how this interplay affects cerebral oxygenation in preterm infants requiring respiratory support at birth. We performed a post-hoc analysis, pooling data from 4 delivery room studies. The population included preterm infants below 37 weeks of gestation who required respiratory support at birth. We conducted a second-by-second analysis of the first 15 minutes of life. Bradycardia was defined as heart rate less than 100 BPM, and infants were stratified into 3 groups based on duration of bradycardia: more than 2 minutes, less than 2 minutes, and no bradycardia at all. Oxygenation status was then further categorized by SpO2 level below or above 80% at 5 minutes of life. I just give you a little bit of background about near-infrared spectroscopy, which is, the acronym is NIRS, and is a non-invasive, painless, and safe measurements of cerebral oxygenation and perfusion. The main parameters are CRSTO2, which I'm going to mention in the following slides, and which reflects the balance between oxygen delivery and oxygen consumption in the brain, and FTOE, which can be easily calculated with the formula you can see in the slides, and gives an insight into the oxygen extraction. Of note, thus indicating preferential oxygen to the brain in the first minutes after birth when we compare these cerebral oxygenation parameters with SpO2. Going back to the results of the study, as you can see in the tables, we created 6 groups. We then built a statistical model to first analyze the impact of the degree of bradycardia alone on oxygenation parameters such as SpO2, peripheral oxygenation, and cerebral oxygenation. And then we explore the interplay between the degree of bradycardia and the presence of hypoxemia. Here you can see the demographics, which I'm not going to describe in detail, but as you can see, the groups were relatively homogeneous in terms of gender, gestational age, and birth weight. Here are the main results, and in the graphs you can see that if bradycardia is considered as a single parameter in figure C and D, no influence has been highlighted in either CRSTO2 or FTOE. And on the other hand, in figure D and F, when hypoxemia at 5 minutes after birth and the degree of bradycardia were combined together, there was a significant influence on both parameters on cerebral oxygenation. So as a conclusion of this study, we can say that this project provided evidence that the combined burden of bradycardia and hypoxemia directly compromises cerebral oxygenation. And this further underscored the crucial importance of achieving both a timely heart rate recovery and adequate ventilation during resuscitation. The second study investigated how tidal volume optimization correlates with heart rate recovery and whether real-time data from the tool you can see in the slides, which is the respiratory function monitor, could support more precise ventilation during stabilization of preterm infants. This was a sub-analysis of RFM studies, including preterm infants less than 32 weeks gestation who were bradycardic at birth and receiving mask PPV in the resuscitation in the delivery room. We examined the first 15 minutes after birth, again, considering this period, the first phase of the transitional phase from intrauterine to extrauterine life. And then we focused on 3 key time points. The initiation of PPV, the time when the heart rate rose above 100 BPM, so when the baby was not bradycardic anymore, and then the final mask inflation before switching to CPAP. And for each infant, we analyzed 10 consecutive inflations at each time point. On the left side of the screen, I show you an example of the traces we analyzed. In the table, you can see significant differences significant differences were found in the peak inspiratory pressure, which was higher when heart rate increased, as well as the expired tidal volume, thus indicating an effective lung recruitment. As you can see in the first red circle, the tidal volume was quite low. You can see in the table that was less than 4 milliliter per kg, which is considered the minimum to consider the lung properly recruited. At T2, however, when the baby was ready to switch to CPAP, the peak inspiratory pressure was decreased to lower value thanks to the respiratory function monitor, and the tidal volume remained stable, set values indicative of a properly acquired functional residual capacity. So we can conclude from this study that a clear corresponding between heart rate rise and adequate tidal volume, expiratory tidal volume during stabilization of preterm infants was highlighted, and our findings confirm that heart rate is a reliable clinical sign of adequate early lung aeration, and also that the respiratory function monitor can be useful to tailor ventilation following real-time changes in lung compliance that we calculated in the study. Study number 3 focused on the feasibility of monitoring transcutaneous carbon dioxide in the delivery room to complement heart rate and oxygen saturation monitoring. We conducted a prospective observational study, including both term and preterm infants born by cesarean section without no need for any kind of intervention. Transcutaneous CO2 monitoring was applied during the first 15 minutes after birth, again. In this study, we analyzed the course of transcutaneous CO2 in both term and preterm infants without respiratory support in a cohort of 66 babies in total. As you can see, in the first 3 minutes after birth, we did not reach any reliable data, but from minute 4 after birth, the data were reliable enough to let us create the normogram. And a plateau was reached at around minute 5. No statistical differences were seen between term and preterm infants at any time points. Our results demonstrated that non-invasive transcutaneous CO2 monitoring was feasible during immediate neonatal transition. However, the first minutes remained technically challenging due to factors such as skin perfusion and sensor equilibration. However, this study, I think, opened the door for future works evaluating the clinical utility of transcutaneous CO2 monitoring, especially in babies, preterm infants, for example, who are at risk of inadequate ventilation or delayed CO2 clearance. The last study, study number 4, monitored with respiratory inductive plethysmography the physiological effects of different settings of non-synchronized bi-level CPAP in the acute phase of moderate RDS, with the goal of optimizing non-invasive respiratory support. We performed a pilot physiological study analyzing respiratory parameters under different bi-level CPAP settings that you can see in the slide. 14 tables were analyzed. As you can see in the table, the results showed that bi-level CPAP with TI of 2 seconds generated at a higher mean airway pressure compared with both CPAP and the T1 second setting. However, there were no significant difference in oxygenation, ventilation, respiratory rate, or tidal volume between the 3 modes. We did observe a trend toward a better thoraco-abdominal synchrony with the 1 second setting, but this was not statistically significant. But importantly, no adverse events occurred. In conclusion, non-synchronized bi-level CPAP did not demonstrate any superiority over standard CPAP in this group of infants with moderate RDS. Nevertheless, these findings suggest that bi-level mode might be helpful when higher mean airway pressure is needed, and also that the TI of 1 second may be better tolerated. But of course, given the small sample size, further studies are warranted. So in conclusion, my doctoral work demonstrates that advanced monitoring provides a deeper understanding of neonatal transition, and that real-time tools can help clinicians in personalized support. As looking ahead, the implication of this research extend beyond the individual studies presented, and probably the next step is the development of integrated monitoring platform combining all these parameters. And of course, this would allow clinicians to move from fragmented data to an holistic overall understanding of the infant transition. And to do that, AI and machine learning will be very helpful, not only for pattern recognition, but also for predict early deterioration in real time. To confirm the impact, it will be essential, of course, to conduct a large multi-center trial, and equally important will be to focus on the late neurodevelopmental outcomes, so linking the longitudinal follow-up to delivery room data would be desirable. This will require, of course, the interdisciplinary collaboration between clinicians, engineers, data scientists, and the industry. But I think it would be really helpful to move from isolated signals like heart rate and SpO2 to a comprehensive and intelligent and predictive system, aiming not only to save these babies, not to ensure survival of this baby, but also to provide a decision support system to secure the best possible early investment for the future life of these babies. Thank you, and I look forward to answering your question.
Thank you very much for your presentation. It's now time to start with the opposition. And the opposition will be opened by the chair of the assessment committee, Professor Zimmerman, professor of pediatrics, especially in neonatology, at Maastricht University.
Thank you, Pro-Rector. First of all, I want to congratulate you with your nice thesis, which looks at different monitoring perspectives in the delivery room, which is nice and novel. And I want to congratulate your promoters, co-promoter as well, promoters, Professor Gazzolo and Gavdanis. But of course, we are here to ask questions, and you have worked a lot with this respiratory function monitor. So my first question is how to set it up in the delivery room. But I want you to give me a brief answer and focus mainly on the sort of messages that you can give to people that are not used to it. So not the whole setup, because you can talk probably for an hour, but to focus on some important messages. Thank you.
Thank you so much, Professor Zimmermann, for your question, and it's my pleasure to explain you what is respiratory function monitor and how it works briefly, and what are the real advantages of using this in the delivery room. So the respiratory function monitor is a device that height, and it's usually placed next to the resuscitation table. It must be connected to the TPs usually, and then it gives on the screen some information about, a lot of information, more information than we usually have during resuscitations about how the lung is responding to the pressure delivered with the TPs. So the respiratory function monitor needs to be calibrated, and then you set up the TPs as a standard practice in the unit. But then when you set it up, you also put the estimated weight of the baby, and this allows the machine to automatically calculate the tidal volume per kg, which is really important during transition. Not only because if we know how much tidal volume we have a sign of how the lung is recruited, but also because we can adjust the peak inspiratory pressure according to the lung compliance in order to achieve a properly an adequate functional residual capacity. So I think that the respiratory function monitor is really useful.
But where do you put this machine?
Next to the resuscitation trolley, really physically. It's like that high is a screen that you connect to the TPs.
And you need a lot of space to do this? Can you do it everywhere?
Well, I don't think it's not a lot of space, but I mean, you have to think that there are many, at least 2 or 3 people when you attend the preterm delivery, so you need a little bit of space, an extra space. But on the other side, you can use the screen of the respiratory function monitor to monitor heart rate, to monitor the FiO2 you are delivering, because you can also, it's an optional, but I think it's really useful. You can.
So you don't need an extra screen?
No, you can use this screen to do everything. And an additional point of the respiratory function monitor is that you can put a camera on the screen, so you can record the resuscitation you are providing, okay. And that's really great to
review,
to see, and for audits and
okay,
stuff.
Thank you. You convinced me of how to use this. So let me go to the second question. That's about the B-level CPAP chapter. You at some point you say this, the 2 seconds mode, let's say, give it slightly higher. You also showed this mean airway pressure, and it was a bit surprising because it's about 50% of the inspiratory expiratory time, let's say, with the 1 second because you do it more frequent, and you explain this as maybe there is more time for equilibration necessary. To reach this level. But then you say that in the discussion chapter, synchronization during NRS also needs to be further investigated. But for synchronization, you probably synchronize with the respiratory rate of the infant, which is a very small inspiratory time. You even say, in this finding confirms too low T-high settings, for example, lower than half a second, does not allow the system to reach a high pressure level, making the modality not useful. So half a second or lower is not useful, but synchronization, by definition, I think, is lower than half a second. So how would you explain this.
Yeah, I think that among the study that I have performed and described in this thesis, probably this one is the trickiest one because it was really done in, I think it was methodologically very well designed, but in practical it has some limitations, and the small sample size and the lack of calibration, of course, is a limitation. We did not use synchronized bi-level CPAP, which I think it's your considerations are absolutely, I do agree with them. But when you synchronize it, it might seem that you are providing a lowest and inspiratory time. But on the other side, the baby is less fighting with the ventilation somehow. So it's more supportive for the spontaneous breathing of the baby, and it's. Yeah, I think we can say that the baby has not to fight against the BiPAP modality and the clearance.
Because the mean airway pressure might be even lower.
But the clearance
so then you
is
might have to increase the peak pressure,
yeah.
And then it sort of approaches nasal IPPV rather than...
Exactly. So probably, yeah, I think for a non-synchronized this is what we can do if we have no access to, because in this case the baby was breathing in between, was not synchronized NIBPV, yes. But the baby was breathing in between the settings.
Yeah. Okay, let's come to my last question. You write in the discussion chapter at page 82 for the future. You know that I was the medical director of a parent organization, so of course I want to ask you about this sentence: the delivery room setting is the place where human beings are given birth, and NICU is the place where parents live the first stage of parenthood. That's also in the delivery room, I think. And then you say that technique has to facilitate rather than inhibit, let's say, this family integration and bonding. But can you explain this a bit more? I understand the wireless technology, so don't go too deep into that. But can you also imagine technology that sort of helps the bonding, and instead of trying to mimic, to limit the technology in inhibiting the bonding, but maybe there is also technology that helps bonding, and because bonding is very important for also even long-term outcome.
Yeah, well, I think this is a really crucial point to delivery room approach, because it's, generally speaking, it's something that really happens when you deal with preterm infants, because they really need a high level of support, high degree of support. So, of course, we tend not to focus on the medical aspect and the clinical aspect, but of course we are talking about parents, maybe at first parenting, and we are talking about babies. So I think that going ahead and looking ahead, not just on the technology, we should probably consider as an overall approach, which not include just technology. I would not concentrate on that, but psychological support from the very beginning and from the early stage of the delivery room, because of the pregnancy, because probably if the delivery is imminent, you cannot predict that. Of course, maybe the delivery room is not the right place to know your baby for the first time, your preterm baby for the first time, so it can be traumatic, and so maybe we have not a great bonding, not a great start. But on the other side, I think that the pregnancy is followed up. I think it would be really great to have support and to see what the parents really want from the very beginning in the delivery room, because it's likely that they want to be involved from the very early stage. But we, as babies are different, also parents are different. So if you have this kind of support, on overall support among this multidisciplinary support, I think we can do a better job.
Yeah, thank you very much. Time is running fast, so I'll give the word back to the prorector. Thank you for your answers.
Thank you.
Thank you, Professor Zimmerman. The opposition will be continued by Professor Galvano, from the Catania University in Italy, and Professor Calvano is online.
Yes.
The floor is yours.
Morning. Good morning, estimated Prorector. Good morning, dear colleagues, and congratulations for the excellent work that the candidate is presenting. My first question is, I would like to know the opinion of the candidate about the future methods to improve the management in the delivery room.
Sorry, about
the management in the delivery room, future methods to improve the management in the delivery room. So.
Okay. Thank you, highly esteemed opponents, for your questions and to give me the opportunity to give my opinion about the future of delivery room management. I think that we have several points to touch. I think that once I have already mentioned with Professor Zimmermann, because I really think that the delivery room is quite an aseptic, psychologically aseptic setting, while there are many psychological changes happening. So I think we have to focus on this aspect that has been really underestimated for years. And going back to the technical aspects, I think that the wireless technology would be a great advance, not only for the minimal invasive approach to the babies themselves, but also for example, for having additional support in real time, not exactly in the delivery room. So, for example, if you are monitoring a baby, and you are the consultant, you have an additional consultant on call, maybe the consultant can give advice in real time and see what's happening in the delivery room. And that would be great also for the trainees, the pediatric neonatology in training, because they could really play their role with support in any condition. Also, talking about any condition concept, I think it would be also great for low-income settings, which might really benefit from this kind of monitoring. And what I really think it would be desirable is to combine several aspects and several monitoring in just one tool, which is currently not available. And of course, we would need AI and machine learning algorithm to analyze all the information we can get. Because the main point also for the respiratory function monitor is the degree of skill which is needed to interpret the data in real time, and to adjust, not just to interpret in real time, but also to adjust the ventilation in real time, which needs a high degree of skills. On the other side, if you concentrate on this point, maybe you cannot concentrate on the cerebral response. So and the lung and the brain are going really parallel in the delivery room, so, and the heart, of course. So I think we would need some kind of tool which is enabled to combine and interpret the data in real time, and also, as I said in the conclusion, something which is able not only to analyze the current stabilization, but also to predict deterioration and suggest the intervention to be made fast. I think this is the future.
Are you muted, Professor Calvano?
Sorry, I was muted. Yes. I was asking if at this point you consider useful the presence of a psychologist in the delivery room.
Well, maybe not in the delivery room.
Okay.
Yeah, honestly, No, I don't think it's useful. Also because it's an emergency setting usually, so I don't think we need. But in the previous phase and in the following phase, I think it's. I wouldn't say it's useful. I would say it's fundamental, and to date, it's something we cannot miss. You know, these aspects, because they can really have long-term consequences, and with this kind of support, I think we can really improve the outcomes, the baby's outcomes, supporting parental bonding, supporting parental stress, and supporting parents, generally speaking. Yeah, but not in the delivery room, not physically in the delivery room, but as an overall approach to the parents-to-be. Yes.
That's a good point. I come to my second question, and I would like the candidate opinion about the role of NIRS in the delivery room and in the neonatal intensive care unit.
Thank you for these questions, because it really gives me the opportunity to explain a little bit more why we have believed in the near-infrared spectroscopy for the last years. Well, in the delivery room, you know, the results that have been published recently are not so promising as it was, they were supposed to be. From the COSGOD trial, for example, they have proved that they are not, the resuscitation based on the cerebral oxygenation is not going to really change the cerebral accident in the first reduce the cerebral accident in the first 48 hours. So probably we need more evidence to do that, to prove that. On the other side, I think that going from the delivery room to the NICU, the near-infrared spectroscopy has great potential, which is probably hasn't been used completely, because it doesn't just give information about the cerebral status, the cerebral oxygenation status, which means mainly directly connected to the oxygenation, generally, and peripheral oxygenation, generally speaking. So the FiO2 delivery, and CO2 clearance and stuff, but also gives information about metabolic status in general. For example, hypoglycemia is something that it's detectable with near-infrared spectroscopy, even if it's not immediately related to oxygen delivery and FiO2 delivered generally. So I think there are different uses. You can detect several conditions with the near-infrared spectroscopy, not just about oxygenation, but also about, you know, the overall functioning of the baby.
Okay, that's fine. Thank you very much.
Thanks.
Thank you, Professor Galvano. The opposition will be continued by Dr. Hutten, Assistant Professor of Neonatology at Maastricht University.
Thank you, Pro-Rector. Dear candidate, first of all, I also would like to take the opportunity to congratulate you with your very nice work in this book, you and also your supervisors. I was especially intrigued how close the link between clinical work and clinical questions and your research is, which made it for me as a clinician not only even nicer to read, but also gives me the opportunity to ask a lot of questions which I also confronted with my daily work. And the first one is about chapter 5, where you're comparing CPAP and BiPAP, nasal ventilation. And you were comparing a PEEP level of 5 and a BiPAP level of 5 and 7 centimeter water, and my first question would be, why 5 and 7 centimeter water?
Yeah, thank you so much, highly esteemed opponents, for your questions. It's a great question, and I think I have definite answer for that, because there's no evidence of which are the best pressure to set up with the BiPAP. We probably, thinking back to how this study was designed, we could have probably increased a little bit the difference, because 5 and 7 was not that huge difference. And we could have probably increase a little bit the time the baby was put on the several settings, because 10 minutes, it's probably not enough. On the other side, we use this timing to avoid a step-up confounding process, let's say this way. So I have honestly no answer. I can justify the 5 and 7, but I cannot say, honestly, that 5 and 7 are the right ones. So probably we could have used some more differences in the BiPAP level. Yes, I do agree with that. Let's just think that this baby had moderate RDS. So are not the most severe ones.
Yes, thank you. That very nicely brings me to my next question, because as you know, the PEEP level of 5 is a little type of classical PEEP level. You have a growing body of evidence during transition. PEEP levels of 6 or 7 are not uncommon. The ICLA trial taught us that PEEP levels of 10 should be used when we have children after detubation. And in your talk in the beginning, you nicely talked about personalizing our care. So my question would be, which opportunities do you see, which possibilities do you see to personalize the PEEP, and on which patient groups should we focus with that?
Oh, that's really an intriguing question. I think that the levels we choose are really influenced by the time when the study was performed, because it's been a few years now, and in the latest years, a growing body of evidence has been published about the use of increased level of PEEP, which, you know, there has been some period in the past with a sort of pressure phobia and, worried about giving too much pressure. But now we are going in a different direction, where we see that PEEP, the use of PEEP, is an increased PEEP is not damaging, is not harmful, but it's useful to recruit the lung.
And to ask on that, so which possibilities do we have to objectively judge if we are giving a good PEEP? Is it more a clinical judgment? Would it be a new technique like an EIT or an FOT? What do you think? Where are our
It depends on the setting where you are doing research or clinical stuff. With my thesis, I just want to underline this point. I don't want to prove that we need additional monitoring in any setting and in any situation, because for some studies we have proved that heart rate and SpO2 are reliable, indirect signs of adequate lung recruitment, good response, great stabilization. So I think that additional tools are useful to personalize, for sure, but also to give a deeper understanding of what is going on. So the more tools we have, the more we can understand what's going on, and the more we can personalize. But in settings where all this is not possible, which is the majority of the world, I think that this work can be used to validate easily doable clinical signs to personalize support. So I cannot say that we need these tools everywhere, but I can say that these tools are useful for a deeper understanding of what's happening. Yes. And about the PEEP questions, I think, for example, there is an ongoing study about the PEEP in the delivery room, which is run by Melbourne group, is the Polar Trial, where they are using incremental PEEP during resuscitation. And this seems to be, it's going to be closed and going to be published, so I don't know the results in advance, but it's probably a new concept that we have to take into consideration, because the lung is not something stiff, can be stiff and can start stiff, but it can be stiff but not still. So it's something that it's really changing, and so the lung compliance is changing, and so probably we have to adjust in real time. So that's the reason why I'm saying that we need tools that are with AI and machine learning whatsoever, that are able to interpret the data, because they are changing. So we have always provided a sort of still medicine, not medicine, still clinical approach, but we probably have to change mind and to change our way to see things from the delivery room onwards. Yeah.
Is there time for another question? Then I give the word back to the pro-rector. Thank you very much for your answers.
Our next opponent is Dr. Ilia Bresesti from University in Italy, and she's also present online.
Yeah, thank you, Pro-Rector, and good morning. And first of all, I want to congratulate you for this thesis, very interesting, very usefulness. My first question is regarding chapter 4 and transcutaneous CO2 monitoring in delivery room. What do you think is possible, the possible relationship between your data and the body temperature, especially in preterm? Could you elaborate these aspects?
So thank you, Ilia's esteemed opponents, for your questions. It's an interesting question. So I haven't considered this when we were writing and drafting the publication. So thanks for giving me the opportunity to think about that. Well, I think there is some degree of relationship because it's technically, the transcutaneous monitoring is technically related to a sort of some degree of heating of the machine itself, and the temperature really influence, the response in the in the initial fetal to neonatal transition. So about vasoconstrictions and about stuff. So I'm pretty sure that I think I can say that there is a relationship, and that's the reason why we have to be really careful in providing a proper temperature control from the delivery room. Unfortunately, we haven't the data about the temperature that probably have been recorded in all these babies, although all these babies were, let me say, physiological babies, because they were born by cesarean section, and they were term and preterm, but not a high degree of prematurity. They were almost because we included babies without any need for respiratory support. For if they do not need respiratory support, of course, they're not very severe preterm. And so I'm not sure we have recorded the temperature in all these babies, but probably should become common practice to do that to ensure a proper transition. So I think that the transcutaneous CO2 is strictly connected to the body temperature. Yes, I do.
Thank you. I have also a clinical question. Still in delivery room setting, you took into consideration the use of NIRS, transcutaneous CO2, but in a clinical practice, in a concrete case of preterm, very low birth weight infant, already monitored according to guidelines with SEZ, temperature probe, O2 saturation. If you had make a choice between NIRS or transcutaneous CO2, which one would you choose and why?
Thanks for this question. Well, I honestly would reply according to my skill in doing, using one device, one tool or the other. So if I have to say which is my favorite, I think that the respiratory function monitor is my favorite. Yes. But also because you can really go through the traces after you have performed the stabilization. So I think it's really helpful to correct yourself, to see what you have done, to train yourself somehow. So I think it's and I think that after a while you become quite used to see the traces in real and to interpret the traces in real time. Of course, it's not immediate. The NIRS has the advantage of having a punctual value. So you see a number, basically. So if you know the ranges, the reference ranges also for the delivery room, they are available for term and preterm infants. Of course, it's easier to see, because you see a number, it's like the SpO2. You know that at 5 minutes you should have more than 80, for example. So it's easier to interpret. But on the other side, you know, my interest relies mainly on the respiratory. If I have to tell my opinion, my gut feeling about that, I would say respiratory function monitor, yes.
Thank you. I have extra time for another question. Yeah?
Yes, sure.
Thank you. Thank you. And my last question is, what use and usefulness do you think these monitoring tools can have, not only in delivery room, but also during stabilization in spoke center or during transport of the newborn from a spoke to a hub center?
Well, really interesting question. Well, I think we are talking about advanced monitoring, so probably these are mainly, to date, maybe not in the future, but to date they are more, I think they are more easy to set up and used in tertiary centers, honestly. I'm not... the transport would be physically a bit difficult. So if they manage to create something which is available for transport and for the sort of movable RFM, I would be absolutely in favor of that. I know that they are doing something, some studies about that in the UK, but to date, I think it's more for a tertiary. It's a stable monitoring, and mainly for the tertiary centers, I would say, to date. But let's see in the future, because now you must interpret, but you still must interpret the data. If one day we will have algorithm and machine learning technique which will do this job instead of the clinician, I think it would be applicable. Yeah, it's something that it's possible. I think it's doable in the future. Yeah.
Thank you so much.
Thank you.
Thank you, Professor Dr. Pijlen. We now go to the last opponent, and that's Dr. Van Vonderen, pediatrician and neonatologist at Wilhelmina Kinderziekenhuis in Utrecht.
Thank you, Prorector. Dear candidate, I've read your thesis with interest. I congratulate you and your supervisors with such fine science in taking a look at various ways of monitoring in the delivery room and the neonatal ward, as I believe that we can and we must do further research to improve our care. The first question I have is about Proposition 3. which says that the use of a respiratory function monitor is able to guide resuscitation and avoid intubation in the delivery room in the most premature infants, providing more accurate information on the efficacy and response of ventilation delivered. In chapter 3, you say that heart rate is a good proxy for ventilation and monitoring transition. These things contradict to each other, I think. What is your opinion about my statement?
If I could, I do not completely agree with that there is a contradiction in that, because in our paper we proved that the baby was still bradycardic for almost 180 seconds, so the heart rate was quite low for, I think, a long period of time. I think that with the respiratory function, this, if we think and if we believe, and we do, that heart rate is an indirect sign of properly acquired FRC and properly acquired lung recruitment, and if we believe that the respiratory function monitor can guide the resuscitation, I think that the PEEP adjustments could be done quicker than we have done in the study and than we usually do, because again, if we don't know exactly what how much pressure you are delivering, because you set up the TPs, so you know how you have set up, but you don't know exactly how much the baby is receiving, and especially how the baby is reacting to the pressure you are giving, because any lung is different, any baby is different. So you can predict, but you can really see how the lung is reacting with the respiratory function monitor. So I think that when we talk about the avoid intubation in the delivery room, this is another thing, another point that is really important to touch, because if you personalize and you tailor the ventilation in the delivery room, you can correct bradycardia, correct hypoxemia quicker, and then you can avoid ventilation, because of course you can avoid intubation, endotracheal intubation. So yes, I think that's really true.
Okay, thanks. You've convinced me. So you talk a lot about taking a look at the data, interpreting the data, needing time to get to know the screens and the RFM. Do you think that in every hospital in the Netherlands or Italy, such a respiratory function monitor would be necessary?
Honestly, I don't think we can talk about necessity of this kind of monitoring to provide adequate care and safe care, because otherwise we are just denying what we have done until yesterday. So of course we probably have done a great job until now. I think it's not about necessity of having these tools. I think it's about necessity of improving research with these tools about how the baby is responding to what we deliver. That's the main point, because if we deep understand how the transition is going, I think we can really optimize and really tailor the support you are giving. So it's not necessary, but it's really useful, and it's really useful to give a further insight into the transitional process. That's what I think.
And is there a certain age group, gestational age group, in which you would want the RFM if you hadn't have one?
Another interesting questions. I would say probably, because I think that we all tend to be focused on the most premature infants, which makes sense, clinically makes sense, because they are the ones who need more support it's a physiological thing, so we cannot, I mean, it's a statement. On the other side, I think that there is really a black hole in the highest gestational age, so 30, 32, 30, until 36. There are no evidence at all. So I really can see the promising application of these tools and these monitoring devices in a population which is not the most premature. So I think it's really applicable for clinical purposes, but also for research purposes, also in the higher gestational age. Yeah, I think that I would not. I think I would not say that these tools are for the most premature ones, are for any, because the transition is also in term infants is still transition. So I think that I would not talk about gestational age. I would not talk about birth weight. I would probably talk about groups of babies. For example, I think that restricted intrauterine, is really an interesting population to study, for example, because they have different, pregnancy history, and so the response is different. Pulmonary hypoplasia would be really interesting to monitor because the transition is different. It's somehow different. So I think, gestational, I wouldn't say it's a criteria.
So the sicker patients need the RFM, right?
Sorry?
The sicker patients need the RFM.
I think they all need the RFM.
I think you've convinced me. So let's say you have all the money in the world. You talked a lot about things to stick on the RFM, FIO2, these things, video, these things are fantastic to look at it from an educational point of view. But you looked at tidal volumes, heart rate and saturation. If you would have all the money of the world and you would be able to fit them in a way you can take out all the necessary information, what would you really, what's on your list if you would take a look at adequate ventilation? So not based on tidal volumes and heart rate, but basically looking at the patient, seeing how gas exchange develops, things like that.
Sorry, I'm not sure I got.
Yeah, so you looked at tidal volumes, you looked at heart rate and oxygen saturation.
Yeah.
My personal opinion is that's too little for parameters. I would want more. If you would have a big sack of money, what would you want to stick on the
stick on? I think it's a great fight between heart rate and SpO2. Between this is your questions. What I would go for.
I would want more. Things like suggested before, like ERT, things like that. Because
you have heart rate, you have SpO2, you have tidal volumes.
I think we're still skimming the surface. That's my standpoint. And I would want more parameters to know and see what the patient's doing.
What's the patient doing? I think that NIRS is still another option because we don't know otherwise. Because the brain is strictly related, of course, the oxygenation of the brain is strictly related to the lung response. But he has a different response to CO2, to oxygenation. There is a preferential delivery of oxygen to the brain. So I think that I would probably add this. So if I have all the money of the world, I would probably combine all this. Yeah, I think that the brain needs to be protected carefully. Yeah.
Okay, thank you.
Thank you, Dr. van Vonderen. Ilia Bresesti, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
Ilia Bresesti. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Gazzolo is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. Please all rise.
Thank you, Prorector. Do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By authority vested in us by law and in conformity with the decision of committee present, I hereby confer you upon Ilia Bresesti the degree of doctor and grant you all rights attached by custom and law. Congratulations.
Thank you.
As evidence of this, I now present you the degree certificate signed by the Rector, the Secretary, and other members of the committee, and affixed with the official seal of the university.
Thank you.
Okay. Today is the end of a part of our research collaboration, but I think that is a starting point for a fruitful career, and I hope and I trust that you will achieve these targets. Ilia is a very motivated young doctor because we met her 10 years ago, more or less, and we did the first interview by scientific committee in FNPS meeting in Maastricht, in Holland. I don't remember the precise place of the meeting, anyway. Ilia starts to show us what she previously did in different universities, because is a very moving researcher from Oostenrijk to England, then to Milan, when he found a true mentor, Professor Gianluca Lista, and me. Gianluca was was the first senior PhD, and stimulated Ilia to participate to the PhD International Research Project. And from the first time we met, the Scientific Commission have a deep feeling of your motivation, of your the desire to develop a research project and to close your research progress at the due time. And we receive a lot of mail from Ilia. When is the timing? When is the timing? And we have problem with the PhD track, as you know, as all the PhD candidates. But you know, today is we overcome the finish line. And what do you want to say? You are a bright mind. You are a bright researcher. The future is in your hand, and I trust that you will achieve as soon as possible. Congratulations.
Thank you so much.
Dear Dr. Bresesti, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. Of course, I also congratulate your mother, present here, and people watching online, colleagues, friends, family that have one way or the other supported you in getting here today. I'd also like to congratulate your supervisors, Professor Cazzolo, Professor Cavillani, Professor Lista, who is unfortunately not present today. I'd also like to thank the members of the degree committee, especially our guests from outside Maastricht, Professor Galvano, Dr. Peila, Dr. van Vonderen. Thank you for your contribution to this PhD defense in Maastricht University. Well, I can tell you that the committee was very happy with the way you defended your thesis. You show that you're on top of the topic. I hope you also feel satisfied by the way you have been able to defend the thesis. It's now time to relax, to enjoy the fact that you have obtained the degree, and I wish you a lot of success in your future career.
Thank you.
And with this, I close this academic ceremony.
Thank you.